A very good day, my dear postgraduate students. I have started a new series of small topics which I felt would be helpful for us. Prothrombin time is the topic for the day. Nothing new to you, but let us see how much more we can learn. This is our classical friend. I will not be going into the details of it right now. So all of us know that there is an intrinsic pathway, an extrinsic pathway, and a common pathway. This has been studied well. You find that there is another work in which there is an initiation phase and an amplification phase. I am just trying to tell you people how complex a simple clotting mechanism can be. So this is a modern coagulation pathway. And this again is supposed to be an artistic work. It looks a little artistic anyway. I shall be going into the details of it at a later date. And finally, we have got this where there is a concentration on the inhibitors of the various steps in coagulation. Thanks to Wikipedia. Now this is just a recollection. You people will be knowing, after all, what is a clot. There is going to be an entangled mass of cells that is enmeshed by means of fibrin, which is called a clot. Okay, good enough. And what is plasma per se? Blood minus the cells we can call as plasma. And what is the difference between a plasma and a serum? Plasma minus fibrinogen is equal to serum. Let us have this very colloquial school knowledge with us in mind. As I told you people, the topic is the prothrombin time. The prothrombin time is actually done on a platelet poor plasma, to which is added the tissue factor and the phospholipid. It contains this. And incubated at a temperature of 37 degrees centigrade. Calcium is added and the clotting time is recorded. So very simple steps. I think you people can remember it. In fact, you would have been doing it yourself. Principle, procedure, precaution. The venous blood in blue top tubes are taken for this. It contains 3.2% sodium citrate, which chelates the calcium and prevents the coagulation cascade, so that the blood will remain in the liquid form until the testing is done. The sample should not be shaken as it would cause hemolysis after collection. Calcium chloride is added and then the coagulation pathway is set in motion. Finally, the clot can be determined either mechanically or optimally. So this is something, maybe a little bit of physics and chemistry here and there, but we shall remember. The prothrombin time is one of the routine coagulation studies. It is used to evaluate the extrinsic and the common pathways. Please remember there is a logic in this. The extrinsic and the common pathways, and also to assess any dysfunction in factor 2, 5, 7, and 10. Low fibrinogen level, etc. can be studied by means of this prothrombin time. The WHO introduced a term called as INR, which is International Normalized Ratio. This is likely to vary from place to place depending upon the thromboplastin that is being used. And however, this is a standard that should be followed. And when thromboplastin is added to the plasma, it leads to clotting. And what is the thromboplastin? It is nothing but tissue factor plus calcium plus phospholipid. That is what I had shown you in one of the first slides. Now, what are the methods? We felt that it was very easy. Even I thought. But then I recollected that there is one called a Quick's method, a one-stage method, introduced by Armand Quick in 1935. The time required for clotting on a citrated plasma after addition of calcium and tissue thromboplastin. There are also other methods, automated methods. One is electromechanical. Impedance by steel ball. A steel ball rotates in a magnetic field until the formation of a fibrin clot. Another one is an optical method, which is turbidimetric, or nephelometric method, which uses light scattering for study. So these are the methods. I would like you people to kindly recollect them and remember them. So this is the prothrombin time. You find that there is a citrated plasma to which the thromboplastin and the calcium are being added, after which you find that there is the coagulation process which is set in motion. Finally, you get a fibrin clot. So unless this step is going to be completed, you will not be getting the product over here. What are the different methods and the situations? So we had seen the different technical methods, but wherein can we use them? As an emergency, it can be done. In intervention, it can definitely be done. Operating room, when the patient is bleeding, definitely this is a must. Clinical diagnosis, we people do. When the patient is having any symptoms of bleeding or he is on anticoagulants. Vitamin K antagonists, such as warfarin, is being administered. Then the prothrombin time will have to be measured. Monitoring any anticoagulant therapy in thrombosis centers, primary care centers, and sometimes the patient themselves can. So it appears quite simple, but then it should be in the right hands. There are two things over here. Usually the test has got a high turnaround time. It can be as much as 90 minutes. But today you find that we all talk about that turnaround time. And there is a point of care device which can give you the result in about 5 minutes, which is not recommended, and it cannot be done in an emergency setting. What are the indications for it? As we had mentioned earlier, warfarin, vitamin K antagonist therapy. Unexplained bleeding, you will have to evaluate it. DIC, disseminated intravascular coagulation, as a baseline therapy before any of the anticoagulants. To assess the liver function, MELD, it is a model for evaluation of liver disease. And you find it becomes significant in a case of liver dysfunction, vitamin K deficiency, any form of malnutrition, which can include vitamin K also, prolonged antibiotic therapy, and also there is a deficiency of 2, 5, 7, and 10. So this is something that you people will have to remember. That is why I put this asterisk mark. Vitamin K antagonist and antiphospholipid antibodies. So in all these conditions, now see, you have got a plethora of conditions which you people shall memorize. The normal critical range is 10 to 13. Some books give it as 10 to 15 seconds, but then it all depends on the type of thromboplastin that is being used. Normal INR is 1.1 or below. And you find that there can be an increase of 2 to 3. The dose has to be adjusted whenever there is going to be a therapy that is done. Also, you find that these are all some drugs which are given for thrombolysis. Therefore, care should be taken. What is the prothrombin time? There can be certain interfering factors. One is polycythemia. The hematocrit is more than 55 because it can reduce the plasma volume, and because of the plasma, there can be a reduction in the clotting factors. Less sample volume. We are not supposed to use it in minimal volume because again there will be a hemoconcentration. Indwelling catheters should not be the source. Direct acting anticoagulants, which should not be used on this. Storage less than 24 hours. The temperature should be 4 degrees. But prolonged storage can lead to a decrease in the factor 7 also. So these are all certain interfering factors which we shall remember. Polycythemia, reduction in samples, catheters, anticoagulants, temperatures, and duration of storage. What are the precautions and the patient safety? Rule out any of the fasting, whether the patient is in a fasting condition, high vitamin K diet, that should be ruled out, and monitor the patient in conjunction with APTT. Prothrombin time is usually not done alone, it has to be done along with APTT. We shall be seeing in the next class. So Stalperts, this is the reference for it. The more you sweat in peace, the less you bleed in war. A beautiful saying. I was looking for something regarding bleeding and I landed on this. See you in the next class.